I'm going to invite Dr. PRACHI AGASH to speak to us about complications, side effects of pharmacological interventions, mainly atropine, and what do we do then? Yeah.
A very good morning to everybody. Thank you, Dr. Ashwin, for having me on this IC. So the topic is contraindications and complications or side effects of atropine treatment. So I'm going to try and cover the areas where atropine cannot be used. The slides are not moving. Thank you. So by now it's well established that atropine drops are a very good treatment modality for controlling myopia. However, is it a single step fix for control of myopia in all the cases? Let's try to understand this through some case examples. So I've just tried to put down clinical scenarios which we actually encounter in our clinics. So a 1-year-old presenting to us with history of holding toys very close to his face. The cycloplegic refraction revealed a refractive error of -8 diopter sphere in both the eyes. And the fundus is as shown in the picture with a tilted myopic disc, a parapapillary atrophy and a tessellated fundus. The child has been following up regularly. At 4 years of age, the refraction is still stable. What is this type of myopia? I'll give the answers later on. Just have these clinical findings at the back of your mind. Case number 2. A 6-year-old girl presenting with difficulty in seeing the blackboard. Unaided visual acuity was 6/18 and the cycloplegic refraction revealed a refractive error of -1 spherical error. The child has been following up. Over the next 3 years, the myopia has progressed to -3.5. So what is this type of myopia? Case scenario number 3. 8-year-old child, known case of high myopia and glasses since 2 years of age. Current prescription that the child is wearing is -8. Parents still feel that the child has started holding things closer to the face and the glass power has increased, and they were right with the cycloplegic refraction having progressed to -11. The child had a fundus which is again as shown with the myopic disc, parapapillary atrophy and myopic maculopathy. So what is this type of myopia? Last case scenario, 7-year-old child presenting with diminution of vision for distance with an unaided visual acuity of 6/24. Dry autoref readings are -3.5, however have been slightly variable. But on cycloplegic refraction, there is no myopia. The child has a spherical error of +0.5. So what is this type of myopia? So case 1, where the young child had a very high myopia and it remained stable till 4 years of age. This is a case of congenital myopia. So atropine drops should not be used for these patients because they do not progress further. Case number 2, a 6-year-old child who progressed over the next 3 years. This is a case of simple or developmental myopia or school myopia. So this is the cohort wherein atropine works. And these are the patients who can be treated with atropine eye drops. Case number 3, where the young child progressed from -8 to -11 with pathological fundus changes. This is a case of pathological myopia. Again, atropine is contraindicated and should not be used for these patients. Case number 4, any guesses? This is a case of accommodative spasm and there is no myopia. So there is no role of atropine drop. So just make sure that a cycloplegic refraction is done for every patient, at least in the first visit, before you label it as myopia and think of treating this child. So the types of myopia that we know are axial, wherein the axial length elongates, curvatural, where the myopia is attributable to the corneal curvature, positional, which could be due to the position of the lens, and index, which is lens induced, as in diabetics or in lenticonus. So atropine again has to be used only in cases of axial myopia and cannot be used in other types of myopia. So these are the contraindications. Okay, so atropine, as I said, is effective in controlling axial myopia and not in the other types of myopia demonstrated through the case examples. Now we know atropine 1% eye drops leads to a dilated pupil. It causes suspended or loss of accommodation. It causes near vision blur, photophobia and mydriasis related phototoxicity. However, this was a meta-analysis that was published in 2017, which actually analyzed almost 17 papers, which showed a very good result with atropine 0.01%, which we are using, with very minimal effects on the photopic and the mesopic pupil size, with an increase to just 0.3 to 0.6 millimeters, and very negligible effect on the accommodative amplitudes. So it was a very small percentage of kids who had any effect on their near vision in the group that were using the low dose atropine drops. Allergic reactions have been reported with these drops. The allergy could be ocular or periocular. It was more common when the 1% eye drops were being used, or when the low dose drop was reconstituted from the 1% drop. So initially, when the commercially available drops were not available, we were actually mixing the atropine drops with refreshed ears and were prescribing to patients. The good part, so they presented in the form of lid crusting, periocular erythema or papillary reactions as shown in the images taken from the article. The patients responded well with discontinuation of therapy along with steroid ointment, and changing over to low dose commercially available atropine drops seemed to do the trick. The effect of atropine drops on the posterior segment. So we learned through the earlier presentations that the 0.01% atropine drops, one of the hypotheticated mechanisms is working on the dopaminergic system and causing an increase in the dopamine levels through the RPE. Hence, it was thought that it can affect the retina, and hence pattern ERG amplitudes could be modulated by the changes in the retinal dopamine. So, a few studies are there on this. However, this the ATOM study did not notice any significant changes in the full field and multifocal ERGs after 2 years of use. This was a study again done by Dr. Mihir Kothari, where they had just studied 2 subjects, one myopic and one emetropic, where 4 drops of 0.01% atropine were administered in either in one eye and tropicamide in the other, and full field, pattern and multifocal ERGs were obtained at baseline and after 45 minutes. They reported profound reversible reduction in the P50 amplitudes without reduction in the implicit time in the pattern ERGs, as is shown in the figure. However, there's a study that is contrasting to that and probably more recent, where the 14 participants were studied, wherein 0.01% atropine was administered daily for 14 days. 2 sets of steady state pattern ERG was recorded. One was at different contrast and one was at different check sizes. This study reported a small increase in 6% of the amplitude difference between the contrast levels with atropine application, but was not significant. And this particular paper suggested that the retinal processing as reflected by pattern ERG does not sizably change. The implication of this is probably just be wary of giving atropine drops in patients who have some night blindness or some other retinal dystrophy, because it may variably affect the ERG. Then effect of low dose atropine drops on choroidal thickness. This was a paper that's reported that 0.01% atropine alone caused a significant increase in choroidal thickness. It also studied the effect of the hyperopic defocus glasses, which reported a decrease in the choroidal thickness. And when both were combined, the hyperopic defocus glass as well as 0.01% atropine, there was a smaller magnitude of choroidal thinning. Now, whether this is really clinically relevant to us is not very, very clear, but requires further investigation. Effect on the ocular biometry. So we looked at the results from the LAM study, wherein we saw that 0.05% has the best effect on controlling the axial length. However, the effect on other biometric parameters was pretty stable. So the corneal power remained stable across all groups. The lens power decreased slightly across all groups, while the AC deepened equally across all groups. Effect on the muscle balance. A convergence excess consecutive esotropia has been associated with 0.01% atropine drops. Again, this was reported by Dr. Mihir Kothari et al. In 3 patients who had undergone surgery for intermittent exotropia. A good result was obtained post-operatively, where they were microtropes. And on starting 0.01% atropine for myopia, they developed a convergence excess esotropia with high AC/A ratio. However, the good part was that the effect reversed completely on cessation of treatment. So all the side effects that I have just enumerated should be looked for when the patient is called for a follow-up in the first 2 to 3 months after starting the drops. So to summarize, pupillary dilatation and accommodative insufficiency are very common with 1% atropine drops but has a negligible effect with the low dose drops. Ocular allergies were again common with the 1% eye drops and the reconstituted eye drops from 1% drops, but less with the commercially available drops. Effect on pattern ERG is not very clear, but we should be wary of prescribing it in patients having some retinal issues. Subfoveal choroidal thickness increases with 0.01% atropine, which requires further investigation, and it may induce a convergence axis esotropia, so may ensure to do a cover test when you see the patient for a follow-up. So overall, this is a very safe and effective treatment option. Though I have mentioned the side effects, the percentage that we come across is very, very less and is a very, very good effective tool for controlling myopia.